Welcome back to the deep dive. Today we are taking on an almost architectural mission. We're diving deep into the human thorax.
A big one.
It is. And if you're a learner really trying to get your head around those complex three-dimensional relationships, the bones, muscles, vessels, all of it, this is for you. We're going to try and replace those dense diagrams with some crystal clear mental images.
Right?
We've got a really detailed anatomical source, a full chapter overview, and our goal here is to build that musculoskeletal map of the thoracic region. Not just list the parts, but really understand how they all fit together in 3D space.
It's a fantastic mission because the thorax, it's so much more than just a rib cage.
Right.
When we talk about it, we're talking about the entire upper trunk.
Right.
And you've got two main pieces. The external musculoskeletal cage, which is all about mechanical protection, and then the internal cavity. And that cavity is absolutely packed.
What's in there?
Well, all the major life systems, heart, lungs, trachea, esophagus,
Yeah.
plus the big vessels and nerves like these sympathetic trunks. But here's the really interesting part. The protection actually extends beyond the chest itself. Because of the way the diaphragm domes up, that lower part of the cage is actually shielding abdominal organs.
Things like the liver.
Exactly. Parts of the liver, the spleen, even the kidneys are all tucked up underneath those domes, getting protection from the ribs.
So it's both a respiratory pump and a high security shelter. That makes understanding the boundaries just essential. Let's start with that readied framework.
Yeah, the cage itself is a marvel of biomechanics. It's built from 12 thoracic vertebrae at the back.
Got it.
0.12 pairs of ribs, and their costal cartilages making up the walls, and then the sternum anchoring everything at the front.
And to really visualize how it all moves, we need to picture how those ribs connect, especially at the front. They're not all the same, are they?
Not at all. We classify them by their articulations.
Huh?
The true ribs, that's ribs 1 through 7, are pretty straightforward. Their cartilages connect directly to the sternum. Those are the sternocostal joints.
Okay, simple enough.
Then you have the false ribs, 8 through 10. They don't quite reach the sternum.
So what do?
Their cartilages sort of piggyback. They join the cartilage of the rib just above them. That forms what we call the interchondral joints.
It creates a kind of flexible cascade downward, and then you have the ones that are just free.
Right. Ribs, 11 and 12, the floating ribs, they don't connect at all at the front. They just end in the posterior abdominal muscles.
And that flexibility is key.
It's everything. It allows for all that expansion for breathing without being rigidly locked down.
Okay, let's define the openings. The top and the bottom, the inlet and the outlet. Start with the superior thoracic aperture, the inlet. It's pretty small.
It is small. It's like a tight funnel, really. It's bordered by the T1 vertebra in the back, the first pair of ribs on the sides, and the manubrium of the sternum up front.
The key thing to picture here is the slope, right?
Exactly. The aperture slopes forward and down.
Which means what, functionally?
It means that if you look at someone's neck, the very top of the lung, the apex, actually projects up into the base of the neck. It's sitting above the level of the first rib.
Wow.
Yeah, so any major structure like nerves or vessels going from the neck to the arm or into the chest has to navigate over that really tricky, narrow first rib.
And the bottom of the whole cavity, the inferior thoracic aperture.
That one's much wider. It's bordered by T12 posteriorly, the 12th and 11th ribs, that continuous costal arch from cartilages 7 to 10.
And the xiphoid process.
And the xiphoid process anteriorly. Crucially, this opening slopes down and back.
So if you were to measure the depth of the chest, it's a lot deeper near the spine than it is right behind your sternum.
Precisely. And that posterior depth is critical for protecting those lower internal organs we mentioned before.
All right, this is maybe the single most important landmark for everything inside the thorax. The sternal plane.
Yes.
This thing is critical for dividing the whole internal space. Tell us where it lives.
So it's a horizontal line, and it passes through the joint between the manubrium and the body of the sternum. It's that little bump you can feel, the sternal angle or angle of Louis.
And if you trace that plane backwards,
it usually intersects the vertebral column right between T4 and the top half of T5.
Why is that T4, T5 level so important?
Because that is the absolute central nexus of thoracic anatomy. It's the dividing line between the superior and inferior mediastinum. It's the reference point for the aortic arch, for where the trachea splits.
It's the highway interchange.
Is the highway interchange for all of the central traffic, absolutely.
Okay, we've got the cage. Now let's look at the functional parts that line the walls and form the floor.
The muscles. The muscles of the chest wall itself are highly segmented. You have the intrinsic muscles like the intercostal, subcostalis, and the transversus thoracis.
All innervated by those intercostal nerves.
Segmentally, yes. And while they do help with respiration, their main job is actually to stiffen the chest wall
Why is that so important?
to prevent paradoxical movement.
Hmm.
You don't want the chest wall sucking inward when you try to breathe in.
Yeah.
You want it to expand. And you mentioned a fascinating clinical point about the transversus thoracis.
I did.
Yeah, the source material pointed out that because of its deep, layered position, this muscle can sometimes be misidentified on imaging. It can look a lot like pleural thickening on a CT scan.
That's a huge deal.
It is. And in rare cases, another muscle variant called sternalis can mimic focal breast density on a mammogram. It's a perfect example of why this detailed anatomical knowledge can prevent major diagnostic errors.
Powerful stuff. Now, the floor itself. The respiratory diaphragm.
The diaphragm is just this enormous dome-shaped musculotendinous sheet.
What's the key to visualizing it?
You have to remember its shape. It's highly domed on the outside where it attaches to the ribs and spine, but it's relatively flat in the center, right where the heart rests on top of it.
And the right dome is higher than the left.
Always. The bulk of the liver pushes it up.
And the mobility of that floor is just,
Yeah.
it's incredible.
It's the engine of quiet breathing. I mean, during restful breathing, it moves about 2 centimeters. But if you take a really deep breath, that can increase to 7 centimeters.
Wow.
That huge variation allows for these continuous dynamic changes in thoracic volume.
Okay, what about the things that have to pass through this floor? The openings. I hear the classical teaching on this might be a little outdated.
And this is one of the most important takeaways. The old mnemonic is T8 for the vena cava, T10 for the esophagus, and T12 for the aorta.
I remember that.
Right. But recent CT studies on living, breathing patients show these structures consistently pass through the diaphragm at lower vertebral levels, often around T11 and T12, especially during inspiration.
So a surgeon or an interventional radiologist just relying on that classic textbook landmark could be way off.
They could be significantly off, yeah. The dynamic nature of the body that we see with modern imaging really contradicts that old static textbook view.
All right. We've built the strong walls, the muscular floor. Now let's look inward at what they're protecting, starting with the outer lining, the pleural cavities.
Okay, so you have 2 of them. 2 entirely separate, self-contained pleural compartments, one for each lung.
And they flank that central mediastinum.
Exactly. They're lined by this serous membrane called the pleura. We define the parietal pleura, that's the tough outer layer lining the chest wall, and the visceral pleura, which is stuck tight to the lung surface itself, dipping into all the fissures.
And the space between them, the pleural cavity, is crucial.
It is, but it's normally only a potential space. It just has a thin layer of fluid, and it's maintained at a constant negative pressure.
By what?
By 2 opposing forces. You have the elastic recoil of the lung trying to pull inward and the chest wall trying to pull outward. That negative pressure is what lets the 2 layers slide frictionlessly against each other when you breathe.
And when the lung doesn't fully inflate, we get those recesses.
The main one is the custodiophragmatic recess. It's a long, narrow gutter between the lower parietal pleura and the diaphragm. The lung doesn't fill this space in quiet breathing, but it gives you essential reserve capacity for deep breath.
Okay, let's move to the centerpiece, the mediastinum. We already used the sternal plane at T4, T5 to divide it into superior and inferior. Let's break down the 3 areas of the inferior mediastinum.
Right. Think of the inferior mediastinum as having 3 zones right around the heart. The anterior mediastinum is like a small, triangular utility closet right behind the sternum.
Not much in there.
Mostly just loose connective tissue, lymph nodes, and what's left of the thymus gland.
But it's clinically important for one reason.
It is. Mostly on the left side, the parietal pleura tends to deviate outwards, leaving a little bare patch called a pericardial triangle. That spot is sometimes used for minimal risk needle punctures of the pericardium.
Got it. Next, the middle mediastinum, the engine room.
This has all the main machinery, the heart, the pericardium around it, the ascending aorta, the tracheal bifurcation, the main bronchi. All the pumping and airway stuff is right there.
And finally, the posterior mediastinum.
This is the long, narrow corridor that runs vertically behind the heart.
The highway.
The highway. This is what connects the neck and thorax to the abdomen. It has the descending aorta, the esophagus with its vagal trunks, the azygos venous system, and the sympathetic trunks running along the spine.
Let's shift to the plumbing and wiring of the chest wall itself. Arteries first.
Okay, so the wall gets blood from 3 main sources. The internal thoracic artery up front, the supreme intercostal artery up high, and the descending aorta, which gives off all the posterior intercostal arteries.
And the genius of the system is how the front and back connect, isn't it?
It really is. The anterior and posterior intercostal arteries and anastomos, they connect near the top of each intercostal space. And this connection is crucial. It provides a potential route for collateral circulation.
So if there's a blockage,
If there's a blockage, say from aortic coarctation, the narrowing of the aorta, these intercostal connections can actually enlarge to bypass the problem and keep blood flowing to the lower body.
and the veins just follow the same path.
Essentially, yes. The anterior veins drain into the internal thoracic and brachiocephalic veins. The posterior ones, though, they drain into the azygos venous network.
Which is really variable.
Notoriously variable. Its course and formation can be very different from person to person. A highly personalized drainage highway.
Okay, innervation. The thoracic spinal nerves, what makes them unique?
They keep a largely segmental distribution. Unlike in the neck where you get the brachial plexus or the lumbar region with the lumbar plexus, most of the ventral rami from T1 to T11 just stay individual. They become the intercostal nerves.
Supplying the chest wall.
The chest wall muscles and skin, and the lower ones, T7 to T11, even supply the skin and muscles of the abdominal wall. The big exception is T1, which contributes a lot to the brachial plexus for the arm.
Let's touch on the autonomic system, the sympathetics.
Right, the sympathetic trunks. These are two vertical chains of ganglia that run just behind the parietal pleura alongside the vertebral column. Preganglionic axons come from T1 down to L2, and the lower fibers from about T5 to T12 form the thoracic splanchnic nerves. And what's cool about them is they pass straight through the diaphragm without synapsing in the chest. They're headed straight for ganglia in the abdomen to control abdominal organs.
And the vagus nerves provide the counterbalance, the parasympathetics.
Yes, the vagus nerves carry those preganglionic parasympathetic axons. They run through these major nerve networks, the cardiac, pulmonary, esophageal plexuses, and they finally synapse in tiny ganglia right in the walls of the target organs.
Can you give us a concrete example of what the vagus does here?
Sure. Its pulmonary branches are motor to the bronchi, so they cause bronchoconstriction, and they're secretomotor to the mucus glands. If you're doing a procedure like an esophagectomy, preserving those vagal branches is a critical goal to help prevent things like postoperative pneumonia.
This internal map is so complex, we need to ground it in reality with surface anatomy. This is how you translate that 3D map onto a patient. What are the key skeletal landmarks?
You have to learn to count ribs. Start with a jugular notch right at the top of the manubrium, then slide down to that palpable bump, the sternal angle.
Our T4, T5 marker.
That's the one. And that's where you find the second pair of ribs, so you can count down from there. Lower down, the diaphragmosternal joint is usually palpable at the level of T9.
Let's map the boundaries of the lungs and pleura. Where does the lung apex sit?
It sits high. It projects up and back, maybe 1 or 2 centimeters above the middle third of the clavicle. And to visualize the lobes, you have to map the fissures.
Start with the oblique fissure.
That fissure curves down from the back of rib 4 on the left, or rib 5 on the right, and continues down to the 6th rib in the mid-axillary line.
There's a clinical trick for that, right?
A fantastic one. Have the patient raise their arm fully, and the medial border of their scapula roughly traces the path of that fissure on their back.
And on the right, we have the horizontal fissure.
Yep, that extends straight forward from the 4th costal cartilage to meet the oblique one.
And the lowest limits of the pleural lining, that recess.
The pleura is always lower than the lung itself. It traces a pretty predictable line. It crosses the 8th rib at the mid-clavicular line, the 10th rib at the mid-axillary line, and hits the 12th rib near the vertebral column.
Okay, finally, let's map the heart's projection on the front wall. We're looking for the apex beat.
Right. The cardiac apex is usually found about 8 to 9 centimeters from the midline, most often in the left 5th intercostal space. You can often feel it there.
And this brings us back to that crucial distinction between where a valve is and where we listen for its sound.
Exactly. You auscultate downstream from the valve to hear the blood flow clearly. So the aortic valve sound, for example, is best heard at the right 2nd intercostal space.
And the pulmonary.
Left 2nd intercostal space. But for the mitral area, you listen right over that apex beat in the left 5th intercostal space.
So we rely so heavily on these surface landmarks. But we highlight a really powerful caveat to all this: the huge variation we see in modern imaging.
That's the core clinical message. We use the sternal plane at T4, T5 as our guide. But modern CTs frequently show that many of these major central structures, the aortic arch, the azygos vein junction, and especially the tracheal bifurcation, are often located significantly lower than that classic T4-T5 reference point in many adults.
So the textbook is just a map. You have to expect the territory to differ.
It demands dynamic visualization and careful correlation with imaging for every single patient.
Mhm.
You can't just rely on the old rules of thumb.
We've built the thorax piece by piece today. The strong framework, the sloping boundaries, the dynamic floor of the diaphragm, the critical internal compartments, pleura and mediastinum, and the vascular and neural highways. We wrapped it all up by grounding this in surface anatomy, but with that constant reminder of the wide variation we now know exists.
And that leads to a necessary final thought for you to explore. If modern imaging proves that these established traditional landmarks, like the sternal angle, are often functionally lower or less reliable in a diverse population, how does this force clinicians to fundamentally reevaluate standardized diagnosis and procedure planning? Should textbook anatomy start prioritizing statistical normality over these idealized classical positions?
That's a challenging question for any student or clinician to consider. Thank you for joining us for this deep dive into the human thorax. We hope this has given you a robust mental map of the core of the trunk. We'll see you next time.